thank you so much to join this ACNS webinar. Good morning, good afternoon, good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world, and welcome to this ACNS webinars. The speakers for today's first session is our honorable guest from the UAE, Professor Rasim Aziz. Professor Rasim is the head of the Department of Neurosurgery at the Sheikh Shabab Medical City, Abu Dubai. He is a vastly experienced neurosurgeon with over 23 years of experience dealing with complex cerebral and spinal pathologies. Dr. Aziz is a distinguished professor in both academic and clinical settings. He previously served as the consultant and head of Department of Neurosurgery at the Medic Clinic and a consultant neurosurgeon at Taiwan Hospital. Dr. Aziz received his fellowship in skull-based surgery and vascular neurosurgery and new and anatomical study at Keio University in Japan. He then completed a research fellowship at the Barrow Neurosurgical Institute in the USA in 2009, after receiving training at the Foundation A. Rothschild in France. Dr. Aziz was granted the Practice Associate Professor title in 2018 in the Department of Neurosurgery at the University of Alexandria. We're extremely honored to have him today at our webinars, and today he'll be talking about single-stage posterior-only corpectomy and fusion for low lumbar spine fractures. The speaker for today's second session is our honored guest from China, Dr. Lu Hua. Professor Hua is a professor of neurosurgery in the Department of Neurosurgery at the first affiliated hospital of Nanjing Medical University, Jiangsu, China. His clinical interests are focused on endovascular neurosurgery. He has received several awards and honors for his outstanding contribution to neurosurgery in his country and has published several articles in various peer-reviewed journals. We're extremely honored to have him today at our webinars, and today he will be talking about endovascular treatment of blood blister aneurysms. The chair for the first section of today's webinar is our honorable guest from India, Professor Sajid Menon. Professor Menon is a professor and chief of the Department of Neurosurgery at the Amrita Institute of Medical Science in Kochi, India. He was the past president of the Neurospinal Surgeons of India. He is an important member and a faculty for the AO Spine Association. His clinical practices include spine surgery, including degenerative spine, deformity, tumors, infection, and trauma. He's also a looked speaker and invited faculty for various workshops and conferences around the country. We are extremely grateful to him for accepting our invitation to chair the first section of today's webinar. The chair for the second sections of today's webinar is our honored guest from Japan, Professor Yoichi Morofuji. Professor Yoichi is a professor in the Department of Neurosurgery at the Nagasaki University School of Medicine in Nagasaki in Japan. He is an expert in the field of endovascular surgery. He was a previous research fellow at the University of Washington, has published several articles in various peer-reviewed journals, and he's also an associate auditor for the Journal of Clinical Neurology and Neurosurgery. And we're extremely grateful to him for accepting our invitation to chair the section of Professor Lu Hua. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, the chair, and the audiences to this online platform ACNS webinar. And a very warm welcome to our colleagues in China, and we're extremely thankful to Professor Xu Bin for broadcasting the webinar on the WeChat channel. And Dr. Liu Singh from Malaysia is my co-host today. And with that introduction, I would like to hand over this online podium to our first chair, Professor Justice Menon. Professor Menon, please.
Thank you very much for your kind words and introduction. Let us start. Lumbar spine is a very common problem, and how to treat this problem is a big controversy, whether to go anterior, posterior, combined, so that we can get a 3-column support. In order to avoid this controversy, there are many methods to go about and do the surgery in these cases. And Dr. Wasim Aziz is coming out with a novel technique where he can do a 3-column or 360-degree reconstruction from posterior alone approach. So we all happy to hear him and eagerly waiting for his experience in this field. Dr. Wasim Aziz, please.
Thank you very much, Professor, for this great opportunity. And I will be happy to speak today about lower lumbar spine fracture from L3 to L5. This talk today about one-stage posterior only corpectomy and fusion for lower lumbar spine fractures. So I have no disclosures. Lower lumbar spine fractures are rare. It represents 40% of all thoracolumbar injuries and are consequence of high impact trauma. Lower lumbar fractures differ from those on the thoracolumbar area. These differences include anatomy, biomechanics, classification, and treatment possibilities. Lower lumbar spine and related discs contribute to 50% of lordosis in the lumbar area. So this is the first case I will present. This is a 17-year-old male patient presented with severe L5 vertebral body comminuted burst fracture with complete spinal canal compression due to run over by a car. All neurological functions were nearly intact. So this is the axial cuts on the CT. We can see how much the canal is compromised. We can see here. And this is the MRI. We can see also the amount of damage to the L5 vertebral body. And this is the MRI axial cuts. And he was operated in another center by this just laminectomy posteriorly and fixation of L5 to L4 to S1. So no decompression done to the nervous structure, just posteriorly by laminectomy. So after the laminectomy, patient did well for a few days, then he started to develop bilateral foot drop. This is the axial cuts after the first surgery done elsewhere. We can see here the amount of bony compression on the canal is still there from anteriorly, and patient started to have neurology. So this is the MRI after the first surgery. We can see still the canal compromised, and it's a little bit better, but still the exit nerve roots is compromised. So to have treatment strategy for this case, we either thought about two-stage operation, decompression from the back again, then anteriorly, posterior approach and screws. This is our strategies we thought about, and this is what we did. Here we can see we went posteriorly again, and then from posteriorly, we could remove the facet on the left side, and we could decompress the canal completely from the back, from posteriorly. And also at the same time, we could insert this large cage from the back between the nerve roots without injuring any nerve root, without cutting no nerve root, without injuring the nerve root. We could slip the cage in between. First, we do put the cage on the parallel plane to the nerve roots. Then after inserting it deep to the nerve structures, we rotate the cage. So first we insert the cage parallel, then we rotate it to the optimal position here. So here is the AB and lateral views after surgery. We didn't change the screws or augment it. We thought it's enough to have this hold. It's controversial, but we decided not to extend the fixation because he's a male. He's a 16 years old, 17 years old male. So we didn't want to have more long segment fixation. And this is the CT after the surgery. We should see how the amount of bone removed from the back to decompress the canal. And this is the CT post-operatively. We can see the cage and it's filled with bone, and there's still the drain there. And this is the CT lateral and AB views and coronal views. And this is the patient after 1 month from surgery. We can see he started to walk again. He has still weakness in both lower feet, dorsiflexion, but he's improving neurologically too. This is another case. It's a 33 years old male patient presented by this L4 fracture, severe fracture of L4 body, burst with complete spinal canal compression. All neurological functions also was intact. So we see here the amount of bone destruction. And here we can see the facets, how it's destroyed on the left side, how the canal is completely in some areas occluded. See the amount of split, bony split in the L4, in the CT axial cut. And this is the MRI. We can see the MRI. There is also disturbance of the intervertebral discs. This is the MRI axial cuts. You can see the amount of bony protrusion in the canal and the amount of soft tissue damage, ligamentous injury. So this is what we did. Also from posteriorly, we could decompress the canal from posteriorly, remove all the bone inside the canal, and then through a posterior only approach, we put the cage the same way. We insert the cage first parallel to the roots, between the nerve roots, and then once inside, we like rotate the cage. So this is, and then it starts to expand it. We first insert it non-expanded, then expand it later on. And this is how it looks inside the OR. And this is the amount of restoration of height and also. So this is the cage after, in the CT follow-up after 2 weeks. And you can see the cage is still in acceptable position with still subsidence here because of the bony contusion or bony like affection in the L3 vertebral body, but the patient is doing very fine. He has no neurological deficits and he's much better. So this is the CT, also axial cuts. We can see it. And this is a plain X-ray. This is another case of 22 years old. We see that all these patients are very young patients and mostly male patients related to work trauma or sports trauma. And this severe L3 vertebral fracture, this is a work-related injury. It was also neurologically nearly intact. So we can see here, this is a CT sagittal cuts, and this is a CT axial cuts. We can see there is no canal. Its canal is very compromised. And this is also the CT axial, and see how amount of bone inside the canal here in this cut. And this is the MRI. And then through the same technique, we could also decompress the canal from posteriorly by removing facet from one side, even part of the transversal process. And through this lateral approach, we can put the cages the same way, first parallel, then rotate it inside. And this is the cage after insertion in the CT follow-up. And we can see the patient is doing very well post-operative. The cage size is very good. And then this is another case. I can show you how the difference we do between only one stage, single stage posteriorly, or this patient we did the classical or the other way, which is one stage posterior, then anteriorly reconstructed. So this is an L5 vertebral body complete fracture. We can see also the amount of trauma to the L5 vertebral body with bone fragments inside the canal. This is a male patient who went a sports injury by, he was paragliding and fell from high. And we see this amount of destruction to the vertebral body and facets and lamina. This patient came nearly complete nerve injury. He has only flickers in the foot. He also has this pelvic fracture, open symphysis pubis. He has lung contusions. He has open fracture of the tibia. And here, this is the MRI of the lumbar canal. This is on presentation, and we can see the amount of trauma to the soft tissues too. So this is what we did in the first stage. We did lumbopelvic fixation with decompression of the canal. We just didn't do any reconstruction from the front. We did the fixation, and then we did first the decompression and then the fixation percutaneous. So this is after the surgery, first stage. We can see we decompress the canal completely here. Only small bone fragments, but the canal is mostly decompressed, and the fixation is performed. So this is from posterior. You can see we just removed half of the lamina. We didn't remove all the full lamina, just on one side, and we could decompress all the canal from posterior like that, and with the fixation, and this is the result. Then when we did the fixation, our orthopedic surgeon came and fixed the pelvis from anteriorly and posteriorly. And then later on, after 2 weeks, the patient improved because he has a pelvic hematoma, he has lots of issues in the pelvis, so we couldn't do the anterior approach directly. We waited 3 weeks. When things settled down, then we came and inserted this cage from anteriorly. So this is the cage from anteriorly. This is the CT post-operative too, after some time. And you can see here, the canal is decompressed, the anterior and posterior reconstruction done. And this is the picture of the cage and the patient. And this is the patient after few months. He started again to return to gain some function in the lower limbs. He can stand, he can walk, he has some weakness, but he's still training. He's a sports guy. He has a very strong will. So take-home message: the surgery for lower lumbar spine fracture should include decompression, maintenance of lumbar lordosis, rigid posterior instrumentation over minimal segments, anterior columnar reconstruction, aberrative rest, and bracing. There is no satisfactory anterior stabilization devices that would optimally correct the lordosis. There is difficulty of anterior access to the lower lumbar spine because of the great vessels, makes this option technically demanding. Treatment of lower spine fractures must be individualized and taken into account the injury pattern, neurological deficits, biomechanical deficiencies, the limitation of surgical implants and anatomical approaches available. In our experience, a posterior-only approach can be used safely for both decompression and stabilization without anterior approach. Thank you very much. So I want to show this. This is Serabium in Egypt. And you can't imagine how they could introduce all this very big sarcophagus through a small tunnel to be rested in its place. This is the design of the Serabium in Egypt, in Saqqara. And you see this sarcophagi, they could move it all the way to this tunnels and rest it in these places here. So
Thank you very much, Dr. Qasim Aziz, and it was a nice presentation, and all the cases are shown as severe injuries, and you managed it very well. I have a question, if you are pleased to answer. What is your technique for the decompression? Are you going transpedicular decompression or?
Yes. I go transpedicular, transfacet. I remove the pedicle and remove the facet.
Okay. So all
sometimes I need to remove the transverse process too, part of the transverse process.
Transverse process as well as the facet joints you remove and
the pedicle, yes.
Go in. Okay. So from the posterior approach, how will you ensure that dura is decomposed? Because if you go from posterior, it is very difficult to see the underneath or the anterior part of the dura, where some fragments. I can see in one of your cases, one fragment was missed there in the canal, no?
Yes. So I, for sure, the side which is my side, which side I operate, it will be easy to ensure that the dura is completely retracted. From the other side, I depend on experience and depend on that I see that the bone, I usually try to get the bone down, like push it down. And if I couldn't do that, I will open from the other side too. But usually I do it from one side.
Okay.
And in these cases, I don't need to be 100% like decompressing the canal. If I widen the canal enough, the patient usually do very well. Like
yeah,
for
right.
Yes.
Yeah, in thoracolumbar fractures, which is very important because that you cannot leave any fragment there. There we use an endoscope, whereas 70-degree endoscope can visualize the under part of the dura.
Yes.
So you can use that if you need to be sure about the movement.
Usually I push the bone down in the contralateral side.
Yeah.
More than decompress.
Another question: have you ever tried the ligamentotaxis technique to decompress?
Usually, yes. I put the cage and I open it. It helps in the ligamentotaxis. I use the cage to do that.
Okay.
When I insert the cage from posteriorly and I rotate it and put it like that and start to open the cage, usually it do this function.
Last question probably, because see bone grafting, see, if you are using an expandable cage, if you put graft inside the cage, when you expand it, it will not reach both ends. So
Yeah, we supplement it with more bone graft from outside, from through the funnel
both
or through
sides.
the
Or
with more from even around the cage. I supplement it with more bone around the cage.
So that's a great presentation and great technique, and I congratulate you for that presentation, and thank you very much.
Thank you very much.
Hello, Professor Wasim. So I will, there are some questions also in the chat box, and Dr. We talk about the use of the bone grafts, but also Dr. Ayman Ali Mayas asked about, can you give more details about the corpectomy from posterior, and what is your from your experience, is it not enough to do only the posterior instrumentation and laminectomy in your cases?
Can the question again? Can you ask me again?
I think mostly is about so how do you compare your technique? So when is corpectomy?
Can you give more details about the corpectomy from posterior? Yes.
Yeah, and also how do you compare the corpectomy with the posterior instrumentation and laminectomy alone? I think that's the problem. That's the question.
Yes. So we can see here the CT. We can see the bone is completely shattered down, completely burst. So this is just a bone fragment. It's very loose. If you have a good instrument, you can gradually, and if you do the good exposure by like here, like we can see here, I remove the pedicle from this side, I remove the facet from this side, I remove the part of the transverse process all laterally. I didn't come to the canal at all. And then from this side, I have a very big space to come and remove the bone step by step. This bone is fractured and shattered, and it's a piece in pieces, and I can still remove it in pieces. I don't need to have so much effort. Because if the bone is not fractured like that, there is no need to do all this. But here the bone is completely in pieces. And so when I have this space, I have two roots in front of me. And in between these two roots, I have the cage. And when I insert the cage, this diameter of the cage usually fits very well between two roots. So I insert the cage parallel. And then once I'm deeper to the nervous tissues, deeper to the nerves and deeper to the dura, I start to rotate the cage.
I see. So can I ask about like which kind of cage, which brand or which company you use for the cage?
Usually I have two companies with me. In these cases, I don't bring only one company. I bring two companies because sometimes this company hasn't the good shape of cage. Yes. So usually I bring two companies, usually Medtronic and Uvasive, Medtronic and Globus. Yes, so I never rely on one company only in this.
That's what I want to ask. Like how do you choose which kind of implant is the best?
Usually I try to see the cap because the most important for me is the lordosis. So I try to use like here, like this cage. I took time to have, because this is L5S1 and I needed a good coaptation. So to get these two caps, it's not present with every company. So I choose to have these lordotic caps on the cage. So it's according to the anatomy and the availability with the company too. So usually I get two companies and I try to adapt, choosing the cap, the most lordotic one to fit into the situation.
So would the size of the implant would also be important, like if you for the corpectomy to enough support. So what's the size, the diameter of the implant that you need at least to give the stability? Would that be a matter?
So that's why I try to use a bigger cage, the biggest, like the lumbar cages, not the thoracic, not. So I use a lumbar cage, like this is a lumbar cage. And I think it's better to have this, like the flap which has end plates. I will try it next time. to use one with a more end plate support. But I think this is enough too.
I see. Thank you. Thank you so much.
And also there is bone here in front. Still, I don't remove completely the bone in the front. I leave some bone in the front, and this gives like here. There is still bone. This bone will heal also. I don't need to remove this bone around the cage in the front. So leaving this one is also good because it will heal and support the cage more and prevent the cage to go forward.
Yes.
So this one is completely there.
Thank you so much, and congratulations to your case.
Thank you.
So may I ask, are there any further questions from the floor? Or... So if not, I would like to thank you, Professor Menon and also Professor Wasim for the first section. So maybe shall I invite our chair of the second section of today, Professor Yoichi Morofuji, to introduce our second speakers. Professor Yoichi?
Okay, so let's move on to the second speaker. Good evening, everyone. It's my great pleasure to welcome you all to this fantastic ACNS webinar. I'm Dr. Morofuji from Nagasaki University, Japan, and I will be serving as a chair for this talk. Let me introduce the second speaker, Professor Hua Lu from the First Affiliated Hospital of the Nanjing Medical University, Jiangsu, China. Professor Lu will be giving a talk titled Endovascular Treatment of Blood Blister Aneurysm. Blood blister aneurysm, BBA, is a very challenging disease. In Japan, it's difficult to use the flow diverters because of the insurance system. BBA is characterized by a wide neck and dissecting appearance, predisposing them the peri or intraoperative rupture due to fragile wall. We may apply direct surgery, neck clipping, or the lap clipping, trapping with or without high flow bypass, or endovascular surgery like the stent assist coiling or the flow diverters. Because of the high risk of the perioperative bleeding, it is still controversial from the treatment of the BBS. Today, Professor Lu will be giving a talk from the viewpoint of the endovascular treatment. Professor Lu, could you please start your lecture?
Okay, thank you. Good evening, everyone. I'm Lu Hua. I'm from the First Affiliated Hospital of Nanjing Medical University, China. Our hospital is also called Jiangsu Province Hospital. Today, my topic is the vascular treatment of blood blister-like aneurysm, BBA. There's no disclosure. BBA is a refractory aneurysm with high recurrence, mortality, and morbidity. BBA is an exceptionally rare, accounting for 0.3 to 1% of all intracranial aneurysm. They typically arise from the anterior or superior wall of the supracleloid segment of the ICA. Pathologically, BBA is characterized by the absence of vascular intima and media, with the aneurysm wall composed only of adventitious and fibrous tissues. Recent single-cell sequencing studies have revealed a marked reduction in vascular smooth muscle components in this lesion, which may contribute to their fragility and rapid growth. The diagnosis of BBA is based on specific imaging and intraoperative criteria. Today, we talk about how to endovascular treatment of BBA. So imaging diagnostic criteria is important. The imaging diagnostic criteria include: 1 is location. Aneurysm located on the anterior or lateral wall of the supracleloid ICA. 2, absence branching. There are no branching vessels at the location of the aneurysm. 3. The first vascular imaging indicates that the maximum diameter of the aneurysm is less than 10 millimeters. 4. Aneurysm correspond to SH bleeding site. 5. Rapid growth. Rapid growth, re-examination of vascular imaging within 2 weeks, receive rapid growth of aneurysm. The contour of the aneurysm wall or the parent artery wall is irregular. Definite diagnosis of BBA requires fulfillment of criteria 1 to 4 and either criterion 5 or 6. Criteria 5 and 6 are critical confirmatory features. A definitive diagnosis requires BBA can be classified into 4 types based on their morphology. Type 2, present as a small protrusion on the ICA without distinct aneurysm neck, easily missed on initial angiography. Type 2 is most common. A berry-like morphology with a broad base leg not exceeding ICA diameter, accompanied by pathological changes in the adjacent arterial wall. Type 3, longitudinal extension along the ICA with leg length surpassing ICA diameter, indicating extensive vascular wall involvement. Type 4, circumferential involvement of the ICA lumen, angiographically manifesting as diffuse arterial wall dilatation. These 4 subtypes likely represent the sequential development stage of BBS, forming a continuum rather than distinct pathological entities. The optimal treatment strategy for BBA remains controversial. Surgical intervention includes direct clipping, wrapping, aneurysm trapping with bypass, and the endovascular strategy for BBA includes stent acetylcholine embolization, coverage stent implantation, and flow diverter implantation. Actually, endovascular strategy has a lower mortality and morbidity compared to open surgery. Let's take some cases. The first is stent acetylcholine embolization. These techniques include single stent assisted coil and multiple stent assisted coiling embolization. Compared with single stent assisted coiling, the use of multiple stent assisted coiling demonstrates a significantly high complete exclusion rate. Single stent assisted coiling was identified as an independent risk factor for BBA recurrence. This case is from article. We can see the patient is a 49 years old female presenting with sudden onset of severe headache. And the author just used only 1 stent, Elvis, braided stent, to treat this aneurysm. We can see the stent here, and we can see some loop in the sac, just some loop in the aneurysm sac. But the patient is lucky. 12 months follow-up DSSU, there's no residue. But this technique actually is reported the recurrence rate of nearly 40%. In our department, we always use several years ago. We always use multiple stent assisted coil embolization. This outpatient is female, 57 years old, sudden onset headache, CT scan issues, SH, and And preoperative management, we use 300 milligram aspirin and 300 milligram clopidogrel. With this patient, we use two LV stents and with the coil. Multiple stents can more effectively cover the aneurysm sac, promote intra-aneurysm thrombosis, and reducing the impact of blood flow on the aneurysm wall. This lowers the risk of re-rupture and ultimately promote aneurysm healing. 5 months later, follow-up DSA shows there's no residue of aneurysm. This is another patient, a male, 47 years old, admitted with sudden onset of alternated conscientiousness for 2 hours. This patient, this aneurysm BBA was located at the right ICA. This aneurysm, like a posterior aneurysm, this aneurysm we use Elvis and Enterprise to stent assisted coiling embolization. If multiple stents are used to treat BBA, we want to achieve dense packing of the aneurysm as much as possible to prevent rebleeding. For BBA, we tend to favor early follow-up imaging. This patient is a 1 week follow-up after operation. There's no recurrence of aneurysm. This is another case. Is a complex. A female, 69 years old. The patient underwent surgical clipping of the BBA and decompressive craniectomy at a local hospital. 2 months later, a cranioplasty was performed. Post-operative progression of hydrocephalus led to her current admission for planned VP shunt. Before VP shunt, we performed CTA. CTA demonstrated recurrence of aneurysm. So we also performed DSA. DSA also showed the recurrence of BBA. This patient, we deployed 2 Enterprise stents assisted coiling embolization. We note this image shows we deployed the second Enterprise. We not only deployed 2 stents, but also achieved dense packing of the aneurysm. This is another patient, 43 years old female, presented with sudden onset of headache. Imaging DSA at a local hospital showed a BBA at the right ICA. Double stent Enterprise and new assisted coiling embolization was performed. Post-operatively, the patient developed left side limb weakness and jaundiced. Imaging DSA demonstrated occlusion of the right C5 segment. After intra-arterial thrombolysis, the patient was treated in the ICU. About 10 days later, the patient experienced sudden loss of conscientiousness and bilateral mydriasis. Imaging CT scan of the stabilization of vital signs confirmed rebleeding. The patient was subsequently transferred to our hospital for further management. Local doctor told me we can put FD to treat this patient. We performed DSA. DSA shows the new stent is properly deployed. So I decided to perform simple coiling for this aneurysm. Simple coiling at this aneurysm. We were also very fortunately to achieve dense packing of this aneurysm. We're just coiling them. 1 year follow-up, there is no recurrence of aneurysm. Then several years ago, we always use stent-assisted coiling to treat BBA, but these techniques have some limitations. A certain risk of recurrence. The surgical procedure is relatively complex, especially due to the need for repeatedly stent deployment, and there is also a higher incidence of complications. With the improvement in endovascular treatment techniques and the development of new materials, especially the coverage stent and the flow diverter, BBA treatment has changed from embolization of aneurysm to repair of parent artery. Willis coverage stent, which was developed in China, is a new device that is specifically designed for the treatment of intracranial complex aneurysms. By isolating the aneurysm cavity and the parent artery, this method could reconstruct the anatomy and restore the normal hemodynamics of the parent artery to treat aneurysms. In a meta-analysis, the intraoperative technique success rate was very high, 99.5%, with a complete occlusion rate of 98.2%. But there is some complications, such as branch occlusion, vascular spasm, and dissection, and postoperative rebleeding. This is a female patient, 49 years old, present with sudden onset of headache. The 3D DSS 3D shows the BBA located at the ICA. Coverage this patient we deployed a coverage stent. Coverage stent are balloon expandable stent, so they are pretty stiff. They are pretty stiff and don't move through the blood vessel very easily. It requires strong support from the access pathway. So we use lung sheath to give more support. This morphology of stent after expansion, which is very okay. This is a morphology of the stent. If we use a coverage stent, we should preserve the branch, especially the ophthalmic artery and the anterior coronary artery. In this patient, this artery was not involved. 1 week follow-up, there's no residue of aneurysm. This is another patient. CT scan shows the bleeding, and this patient, the aneurysm, BBA aneurysm, located at the right ICA. Here, we should multiple angle observation of the aneurysm leg and the origin of anterior coronary artery. In this patient, the distal end of the BBA leg is more than 2 millimeters away from the anterior coronary artery. So we decide to choose a coverage stent to treat this patient. A DSI was performed to assess whether complete coverage of the aneurysm leg was achieved while preserving the branch vessels. This is a follow-up. 1 month later, there is no residue of aneurysm. The anterior coronary artery was preserved. During 3 months follow-up, DSF follow-up, stent stenosis was observed, but the patient was asymptomatic. Antiplatelet and lipid-lowering therapies were continued. 1 year DSF follow-up, the stenosis was stable. The patient is also asymptomatic. This is another patient, male, 69 years old, present with sudden onset of autologous conscientiousness. The BBA was located as right ICN. This patient we also deployed the coverage stent with stent. If we open expand the stent, there's no residue of aneurysm. 1 week DSF follow-up, there's no residue. Three years follow-up, we can see the pulmonary artery was reconstructed. There's no residue of aneurysm and recurrence of aneurysm. But just we said before, coverage stent implantation has some contraindications, such as aneurysm leg located is less than 2 millimeters from a critical branch vessel, or parent artery diameter is less than 3 millimeter or more than 5 millimeter, because we don't have smaller or bigger size with stent. If more than 0.5 millimeter diameter discrepancy between proximal and distal segment of the parent artery, in this situation, it is forbidden to deploy coverage stent. And excessive tortuosity of the parent artery. In this situation, it's very difficult to deploy coverage stent. Flow diverter FD. FD is currently being used to many medical centers, including our department. The approaches include single FD implantation and overlapping dual FD implantation, with or without coil embolization. The FD group demonstrated superior aneurysm occlusion rate compared to the stent acetylcholine group in angiographic follow-up evaluation of BBA. In recent years, we always use FD to treat aneurysm. This case is also from the article. This is that is located here. We can see more like a dissection. The author just use only one pipeline to treat this disease. A year and a half follow-up DSS shows there's no residue of aneurysm. But in our department, we rarely use a single or multiple FD to treat BBA. We typically use FD combined with coil for treatment. This patient is a female patient, 65 years old, presented with headache, and 3D shows the BBA is a BBA located at the anterior wall of ICA. We choose TubeBridge. It's a Chinese product. This TB is a native FD. we partially deploy the flow diverter, then proceed with coiling. Under suitable condition, we want to achieve density packing of the algorithm as much as possible, to decrease the rebleeding. This FD was well deployed, and this is 1 week follow-up MRI. There's no residue of aneurysm, and 3 months later, DSI shows no recurrence of BBA. This aneurysm is another patient, is male, 45 years old, present with sudden onset of headache, and this aneurysm appears more like a dissecting aneurysm with a low dome height. For the aneurysm coiling, we did not shape the microcatheter and directly used a straight tip microcatheter for embolization. In this case, we use Coco FD Latif, which is also a Chinese brand. If we put some coil, we have to very carefully. This is a post-operative DSA. Yes. And 3 months follow-up, DSI shows there's no residue. There's no residue of BBA. And this is the last patient, last case. Is a 65 years old male presented with sudden onset headache. CT scan shows SH, and this aneurysm like a dissection. We also use tube bridge FD assisted coiling to treat this aneurysm. Sometimes we use software to help us analyze the wall apposition and mental coverage and pore density. These parameters are crucial for the FD to function effectively. 6 months later, DSI showed there's no residue of aneurysm. The parent artery was reconstructed. So we'll take a summary. Thin acid coil embolization can achieve relatively favorable immediate occlusion results. However, it carries a long, negligible risk of recurrence. The procedure is technically complex and has a higher incidence of complications. Coverage stent demonstrated excellent immediate sealing efficiency. Its application is limited by anatomic factors such as excessive tortuosity of the parent artery, significant proximal distal diameter mismatch, and the close proximity of the aneurysm of critical branch vessels. FD offers favorable immediate occlusion rates and sustained long-term therapeutic outcomes. FD meets the pathological requirements for vascular reconstruction. FD also demonstrated lower overall complication rate compared to traditional techniques. That's all. Thank you for your time and attention.
Thank you very much for your excellent presentation, Professor Liu. So Professor Liu presented an overview of the BBAs and showed his extensive experience about stent assist coiling and covered stent and flow diverters. So before the question, I have one question, or what is your favorite treatment for BBAs at this moment? You have a very
No.
extensive experience. But what is your best choice at this moment?
Good question. Actually, this method is for me is
Mhm.
3 stage. I think. Now we the first line choice is FD. FD assisted with assisted coiling is our first choice.
Okay. Now we are open for the questions and comment from the audience. Any questions and comments?
Yes. Can I ask a question, please? A couple of questions.
Yes. Go ahead.
Sorry, I have joined lately in the hub of the session. So I would like to ask Professor. I would like to thank him for his nice presentation. Like, if there is no like some cases like that he moved to surgery, like if it is a very small aneurysm or very tiny blister aneurysm, and what about like if there is massive bleeding, like massive intraventricular hemorrhage or massive intracerebral hematoma, what will be the approach regarding the double applicated? Will he refer to surgery or will he do a flow divert? I would like to ask his question. The other thing is like about the tiny small blister aneurysm, which he cannot put some coil on it, and he have like hematoma. Would he do a flow diverter or he would refer to surgery? Thanks.
Thank you for your question. Actually, it's if the patient has a hematoma, maybe we can think about to do open surgery. But as we know, I'm a neurosurgeon. Open surgery is very difficult to treat BBA. We can meet a lot of problems. Sometimes it's bleeding is very we can meet a lot of bleeding. If there is no hematoma in our department, we can choose endovasc treatment for BBA. And what's the I think this doctor has 2 questions.
Wally, do you
Right?
have another questions?
Yeah, the other question was about massive if there is a massive hematoma, what about the usage of double antiplatelets? Because there would be a concerns or no concerns about this.
I can hear clearly.
If there's a large hematoma, so would you still give the double antiplatelet?
No. Yeah, if the patient has a hematoma, we can choose open surgery.
Yeah. Okay. Thanks.
Yeah. So can I ask a question, Professor Luha? Yeah. So first of all, there are some questions in the chat box. Maybe I shall some of them are answer and some is not. So I think Dr. Misa asked about so in which cases do you think it will be better for the surgical treatment? And the second question is from Dr. Mayers, who commented, so the blister aneurysm might be so fragile, so would coil be appropriate in these cases? So I mean, like if there is sometimes the intraocular, especially for this blister aneurysm, so how would you deal with that? And because I saw you have many coiling cases during this experience, how would you handle that?
I think your question is how can choose patient to do open surgery, right?
Yeah, this is the first question. Yeah.
Okay. Yeah. Just I said before, in our department, if just the patient just the CT scan shows just the SH, so we can do we can do the vascular treatment. If the patient has a big hematoma, yeah, we can do open surgery. No matter what the Hunter scale, no matter what.
I see. So how about for the second question? So if there's during the coiling, so if the aneurysm ruptures, so how would you manage this? If there's an intraoperative rupture, how would you manage the situation?
For me,
Yeah.
I think okay. If we we have several methods to we can push the CCA first and continue coiling, and we can put a balloon. We can put a balloon near the aneurysm, and we can ask anesthetist to control the blood. And I think it's this is I think is very it is very important to be don't be calm, don't be how to say it's anxious. But I think every doctor meet this situation will get higher blood pressure. But we try to calm down.
I see. So
Thank you.
And I think just in the chat box, so that there is also mentioned like if let's say in case so surgery is required, and what are the treatment of choice in this situation? So maybe any comments from the forum? Wally, would you give some comment, like if it's open cases, like how would you manage this kind of in open setting?
Actually, like blister aneurysm, it's like a nightmare for surgeon. I think so, because like if it ruptures, there will be like a massive bleeding. So you have to be prepared for the worst. Like you have to dissect very carefully. You have to get like proximal and distal before like manipulating on the aneurysm itself. In these cases, you have to put like temporary clip distal and proximally, and you have to expose the neck from the beginning, and very like careful dissection of the aneurysm. And many of these cases, you can put like a very small micro or mini clips, very small clips on it. And if it ruptures, either you can do like after you are putting the proximal and distal. If it ruptured before this, it's a nightmare, because most probably it will end with a hole in the carotid, and it may end into sacrification of the carotid and doing a bypass. But if you like put a distal and proximal control and dissect very smallly, you can find like a very small neck. And there are some type clips, but I didn't see there are encircle clips, which you can put it surround the whole carotid, and putting a cottage around the carotid and putting the encircle clip. I have saw Professor Spitzler doing this in one of the cases, But it's actually, yeah, this I agree with Professor Liu that these are very difficult cases for surgery. Yeah, unless you have to do it, it's a nightmare.
Yes, thank you so much, Hardy. Yeah, agree. So totally agree, and thank you so much. So, any further questions from the floor? If there's no, maybe Professor Yoshi, would you want to add a final remark on Professor Luha's presentation?
Okay, thank you again to Professor Liu and the participants. So the BBA is a very challenging disease, and I think it's difficult to sometimes it's very difficult to treat properly. So even if the direct surgery or the endovascular surgery is this time, so Professor Liu give us a very extended lecture. Thank you again, Professor Liu.
Thank
I'd
you.
like to close the session. Yeah.
Thank you so much. So indeed we did have a very meaningful night with the spine and also the BBA and vascular management, and it's actually very educational lectures today, and it is a very, and we have a very meaningful discussion. So I would like to thank you the speakers of the first session, Professor Wasim, and also Professor Luha for the second section. And also I would like to thank you the chair of today, Professor Melon, and also Professor Yoichi. So on behalf of the Education Committee of the ACNS and President Professor Yoko Kato, I would like to thank both the speakers today, Professor Wasim and Professor Luha, as well as the chair, Professor Menon and Professor Yoshi, for the time and the support for the ACNS webinars. A special thanks to Professor Xubin for broadcasting this webinar on the WeChat channel. And special thanks to my co-host Liu Bensing for joining me today. And in total, so today we have 1,790 views on all social media. So this is a great encouragement to us, and also so that this is a very meaningful lectures today. Till we all meet tomorrow, and it's a bye-bye from all of us. And thank you so much for joining me tonight. Thank you so much.